Greetings, everyone. Thanks for coming out on a Tuesday night at 7 o'clock and spend some time. Hopefully learn a little bit about the elbow and maybe some conditions that you might be dealing with at home right now. Maybe that's why you're on this call. In any case, I just want to let you guys know that we're going to go over some stuff that common conditions of the elbow that you may be able to, things you might be able to work with at home on your own, or things you can get help with a physician or a therapist. I do want to give a disclaimer. This talk is not intended to diagnose anyone because we're on Zoom, right? We're not hands-on and in person. So thank you. So just to let you guys know, if you did have a high force trauma on your elbow, maybe from a fall or something like similar, you really should seek out medical attention. So I just want to put that out there. And if you do decide to wait, and if you have symptoms that last for that don't start to subside by day 3, you really should start to think about seeking medical attention. I know a lot of folks like to put things off, but if your pain doesn't resolve, you really do need to make sure you didn't have a fracture or something similar. We are going to be talking about conditions in the elbow itself and those tissues that are involved. We're not talking about contributing factors that may lead to elbow pain, such as cervical neck compression problems or other systemic problems that may contribute to elbow problems. Okay, thank you. So we're going to break the elbow down into 3 areas for this conversation. So compressive neuropathy, cumulative trauma, and traumatic injuries. So the first part is compressive neuropathies. We're talking about cubital tunnel here, but everybody knows carpal tunnel, right? Carpal tunnel is so common that it's the most commonly diagnosed condition by your neighbor, friend, or family member if you're dealing with anything with the arm, right? Everybody thinks it's carpal tunnel. So this is cubital tunnel. This is not as nearly as common as carpal tunnel and not nearly as well known. What's different about this is the ulnar nerve. So the cubital tunnel, the carpal tunnel is the median nerve in the palm. This is the cubital tunnel. This is the ulnar nerve in the posterior part of your elbow. And everybody knows that as their funny bone, right? We've all accidentally hit our funny bone and got a sharp pain and dropped whatever we're holding. And, it's nothing funny about hitting that really hard. So we're going to go into this a little bit further and talk about how this nerve is subject to problems because of its location, sitting on the posterior part of the elbow, where it's subject to high tension forces if you leave your elbow flexed. In addition to compression, right? Because it's not very well protected. So leaning on it can lead to problems as well. We'll go into that. Picture here with this young lady on the cell phone. If you had ulnar nerve compression at the elbow, aka cubital tunnel, this would be problematic. This is something we advise you not to do. This could stir up your symptoms, prolonged elbow flexion. Along with that would be maybe driving in your car or sitting in a chair right now, like I am when I'm giving this presentation. Leaning your elbow on the armrest of your chair or your console of your car could be problematic, or just blunt force trauma to the medial elbow. Maybe you fell, something hit your arm, could create swelling, could actually damage the ulnar nerve directly, and could cause cubital tunnel. So what are the most common symptoms with cubital tunnel? How do you know you have cubital tunnel? You usually have the paresthesias, or the tingling, the ulnar side of your hand. So the small finger here and the ring finger on the volar, the palmar side of your hand, and the dorsal side of your hand is typically where you would kind of feel that numbness and tingling. So that's a main symptom. You might be dropping items, like things just kind of fall out of your hand. You may notice you're having trouble to open containers. Your hand just feels generally weaker. So if you came in the clinic and you saw a therapist, they would kind of run you through it. I just want to share with you what would we look for to kind of confirm the cubital tunnel syndrome. We would do a Sims-Weinstein, this monofilament test, testing your sensation of your fingers, especially the ones that are innervated by the ulnar nerve, making sure that you have proper sensation. We can grade this to a level of being protective or loss of protective sensation, or normal. So we know if you're safe to like handle hot objects or sharp objects where if you have a loss of sensation, you may cut or burn yourself and not even be aware of it. So there's a risk factor there. As you see here in this lower left-hand corner, atrophy is a further onset of nerve compression. And with cubital tunnel, you can get atrophy of the ulnar innervated muscles of the hand. And here we're seeing this little picture here shows the dorsal interossei. These are the muscles that are responsible for spreading your fingers. And you can see that there is wasting away, sinking down of this muscle on the dorsum of the hand here. Someone like this, we saw someone come in the clinic like this, they would be considered severe cubital tunnel or ulnar nerve compression, depending where the location of the compression is. And they would be considered a surgical candidate almost immediately, unless there was some reason, maybe age or health, that they couldn't receive surgery. We'd want to do surgery on a patient like this, or a doctor would want to do surgery to stop further progression of muscle loss. Most likely the muscle will not return once you have atrophy like this, but we can stop it from getting worse. We would also look at strength, grip, and pinch strength. Like here, we're doing a lateral pinch, and that pinch could be especially effective with ulnar nerve compression and dexterity, fine motor manipulation. That might be also effective. So we want to take measurements. We always do bilateral measurements. What's normal for that patient? We have normative data on this, meaning what's norm across the population, but the best data is the unaffected side. So what's normal for that person? We also do special tests in the clinic to see if the nerve is compressed. When a nerve is compressed, it becomes irritated. And when it becomes irritated, it becomes sensitive to any pressure. So one of the tests we do is just an elbow flexion test. We just flex the elbow and hold it there for a minute. If that elicits that numbness and tingling in those ulnar fingers, that would consider be positive. A Tinel sign, that's using percussions or tapping over the nerve directly. Again, a normal nerve that's not irritated, you tap over it, it doesn't really let you know much. But an irritated nerve, you tap over it, it's going to send electrical feelings down the arm, maybe into the hand or up the arm. If you're under the care of a physician, EMG may be ordered as well. That tests your nerve conduction and the health of the nerve, and it puts some data to the nerve and lets the doctor know the severity of your nerve compression as well. And you usually grade it like mild, moderate, or severe. The severe cases may automatically go to surgery. But the more mild to moderate, they usually get sent to therapy and see what we can do with them. So what will we do with them? So someone came into therapy for cubital tunnel. The first thing we want to do is calm down that nerve, right? Stop beating that nerve up. So how do we stop beating that nerve up? We want to protect it. The number one way to protect it is at nighttime. A lot of folks sleep, and you guys might even know, like, you watch a TV, maybe your hands are like this, or you're sleeping and you feel like your hands go numb. Even me, I'm on the, bed at nighttime with the phone, and my fingers you start getting tingling after 20 minutes on the phone. So this is a elbow extension splint. So it's soft, it's fabric with a little plastic stay in there. We would have someone wear this while they sleep to keep their elbow in fair amount of extension where the nerve is at rest, versus being flexed where the nerve is being tensioned across the back of the elbow. With any nerve compression, we're going to look at ergonomics. We're going to look at, is someone, sitting, maybe they work at a desk, maybe they work in the trades. How do they do their job? We can break down their job tasks and figure out, is there better ways or ways we can protect their nerve better and do their job differently, right? So we'll work through them with that is very important, kind of discovering what's the irritating things during the day for that patient. And we keep honing in on, we limit prolonged elbow flexion. That's the number one thing of compression, is just like leaving your elbow flexed too long or putting pressure over it directly. So we would also want to increase the blood flow to the nerve itself. And there's a couple ways of doing that. So we want to do active range of motion. There's different ways of doing that. It just increasing the blood circulation is beneficial for the nerve. And then more specifically, nerve flossing. And nerve flossing is a specific term that we use that means we're not increasing the tension of the nerve. We're just moving the nerve. So if the nerve is irritated, we don't want to stretch the nerve, which your nerve can stretch. But in the early phase of rehab, we want to just move it and increase the nutrition and perfusion of nutrients into the nerve by moving it. You can see this slide's great. This picture's great. This guy put a kind of traced out the ulnar nerve with this cord, taped it onto his arm. You can see when it goes across the posterior part of the elbow, it gets flexed around, right? That increases the tension here. But if he has his wrist flexed, it creates slack. And that really illustrates the point that we're going to make with flossing, is that if you move two joints in a certain series, we can actually just move the nerve without increasing the tension. So for the ulnar nerve, we specifically move the elbow into flexion and put the wrist into flexion. And then we would extend the arm into extension and extend the wrist back, if you can see my hand. And we would have them do that for a series of repetitions without creating symptoms, just moving the nerve. And we would focus on strengthening of those, especially those ulnar nerve innervated muscles. As pictured here, those interossei that pull the fingers together. We're doing a little putty to do a little strengthening there, just for example. So what if conservative management therapy fails, right? You did all the things, you're splinting, we did therapy, and your symptoms are still high. What options are out there, right? There's surgical interventions. Or, like I said, you had atrophy from the beginning, or you had a subluxing nerve that's being really irritated, like other reasons, you would be surgical candidate. So these are the two most popular surgeries for cubital tunnel. One's the in situ decompression, which is a minimally invasive procedure where they just cut Osborne's ligament here. It kind of like, think about it as like a little canal. The cubital tunnel is like a little canal, and they just open up the roof. And that's all they do, is open up the roof. The doctor, while the person's on the OR table, would move the elbow. As long as the nerve doesn't sublux out, come out of that groove, then the nerve's okay. They sew you back up, and you have a minimally invasive nerve decompression. But the gold standard is still this anterior nerve transposition. I'll discuss that a little bit. So what they do is they take this nerve, like I've been saying, it sits on the posterior side of your elbow. They move it forward to the anterior side. They bring it all the way up. See this metal retractor here? They bring it all the way up here and sling it up. And so now when you flex your elbow, it's actually on slack. The nerve has all this extra length to it. And so it's really in a much happier place if it's been irritated for a while, and you can start to recover. Typically, these do very well, depending on how severe your nerve injury was. We usually start strengthening about 4 weeks and kind of return to normal tasks around 8 weeks or so. But the return to sensation in your hand, say your hand was pretty numb, and that nerve grows 1 inch a month. So roughly it would take you over about a year to regain sensation in your fingers, totally, and potentially, because it depends on the severity of the nerve injury. Like I said, the nerve, if you have atrophy in your hand, we can prevent it from getting worse, but usually does not come back much because of the changes in the muscle quality during that time. So now moving into cumulative trauma. So we're going to put into these, what is cumulative trauma, right? So it's low-grade repetitive activity that causes a problem over time. So we're going to talk about our lateral epicondylitis, which is tennis elbow, medial epicondylitis, which is golfer's elbow, and we're going to talk about arthritis, right? Just to let you know that lateral epicondylitis is 10 times more, you're 10 times more likely to get lateral epicondylitis, tennis elbow, than golfer's elbow. Much more common. And everybody, most of the patients that come in, we're not playing tennis or golf, right? Most of our patients that come in are not playing these sports, but there's a high prevalence of this condition with that sport. So that's where the name comes from. So everybody just kind of feel down your arm, your humerus, and you feel that ridge on the outside of your arm as you go down right at your elbow. That's your lateral epicondyle. That's a bony ridge of your humerus. And if you just step off of that towards going more towards your hand, um, you could kind of feel that soft tissue there. That's the common extensor tendon. So that is the tendon that the wrist extensor is attached to. So that's the muscle group that's attaching there, and that's wrist extension is usually a problem for lateral canalitis. And the other side, flip over, Goffer's cell with the medial epicondyle, which is actually a much bigger side of the bone. It's much bigger than the lateral epicondyle. It's a bigger muscle group. That you can step off going towards the hand, feel that tendon. Now, if anyone in the group here has tenderness at either one of these, right, that you can feel both sides and see there's a difference. If you're dealing with a little tennis or Goffer's elbow, that might be indicative there. So then that's a wrist flexor group that goes there, and the pronator that helps rotate your forearm. And the funny thing about these conditions are, especially the tennis elbow, is that the patients that come in to the clinic, and even before if they come to us directly through direct access or they go see their doctor, the breaking point for them, which is pretty consistent between all of them, is I couldn't lift a cup of coffee anymore. And that's the thing that drives them to go seek help, right? They kind of manage through it or pull through it, and then they just can't lift a cup of coffee anymore. And they're like, oh, I got to do something about this. It's too much. So so seemingly it kind of comes out. I was just going to say epicondylitis to deal with both of them. This condition seemingly comes out of nowhere for a lot of folks. They're just not really sure how they got there. Some people do know, maybe they were helped to move to a friend's couch, or was doing a new activity, or they tried to catch something and something yanked their arm or something like that. They had a specific thing that happened. But most of the patients are like, I don't really know. So you got to do a little detective work as a therapist. We kind of figure out working with them, and we really want to know the etiology here. What caused their problem? Because we want to stop it now, because if we're trying to rehab them and they're still doing the thing that got them here, we're kind of like we're putting the water on the fire and they're putting the gas on the fire, right? We're not going to get anywhere. And then we also want them to understand, so in the future they can avoid these problems and kind of steer away before it becomes an issue again. But often, it's from a newer activity that they're just overlooking, maybe a house project, maybe just a new gym routine, just like they're just doing weights a little different. It could be poor ergonomics, just over and over again. Like that's why I got this guy pictured of this box, right? Just lifting over and over again with bad ergonomics could cause tendonitis. And not to, forget about direct trauma in the elbow, right? If something hits you on the arm, that could cause you a problem as well. So how do we know we have lateral or medial epicondylitis, right? Point tenderness usually, right? Point tenderness at those locations I was just talking about. That's the first indicator, right? Okay. There could be other things that do that, but that's the first part. Usually soreness that kind of runs down that muscle group. It can radiate all the way into the wrist because those muscles move the wrist. So a lot of times that pain can travel down that muscle tendon unit. You notice a weakness in grasp or lifting ability. It just hurts, right? And that's what we would test in the clinic. We would test your grip strength in various positions to see if we elicit a difference based on stressing that muscle unit differently. We would do special testing, loading those muscle groups to see if that elicits your pain. And not to, just to touch, the doctors also may do like x-rays if you see the doctor, just to rule out, we're going to talk about arthritis, to rule out arthritis, to rule out like loose bodies, which is like fragments of cartilage usually, bone spurs and stuff like that. Again, arthritis stuff, any other thing that could be happening, a fracture that you didn't realize you had. An MRI, usually MRIs are not given in the beginning of this. Usually that's given, if given at all, if someone's failing to get better over time. Regardless, these conditions take forever to get better. They don't get better in weeks, they get better in months and sometimes a year. So what do we do for them when they come in the clinic, right? If someone comes in really symptomatic, we would use a wrist splint just to calm them down. But most people are coming in a little bit past that point. They might be wanting to still, they might still need to work, right? A lot of folks are working with pain. So we might do this counterforce brace, or they want to still do a sport, which we'd advise against, but that's the picture here. Counterforce brace, why? Because they work in Amazon warehouse, right? And they got to lift boxes. And they wear this brace. And then how that brace works is a mechanical device, really. It just disperses the force from the muscle activity from going into that tendon as much. It kind of just disperses into your forearm by a way of like, there's this little pillow pad there that helps pinpoint the muscle and kind of press it down and then disperse the force. So it works really well. Not something to be worn while you're relaxing on the couch or to sleep or anything like that, only with activity. Activity modification is huge with this population. So let me just talk about tennis elbow. Like for tennis elbow, we would immediately have people stop lifting, palm down and elbow extended, right? That's so provocative for that condition because you have a long lever arm on that muscle group. So, and everybody's like grabbing stuff like that, right? You're just like, oh, I'm in a rush. Let me grab these shopping bags. Let me grab the laundry out of the washer. There's a million reasons to do it. But now the safe way to lift for that affected arm would be elbow flexed and palm up. That's what we would instruct those folks to do. And if you had medial epicondylitis, it would be the opposite. It would be elbow flexed and palm down to shut off that muscle group. We would focus a lot on our manual therapy techniques for this condition, which is stretching out the muscle, using an instrument-assisted device like this, doing some deep tissue work, and negative pressure, which is known as cupping as well, to bring blood flow into there. This condition is often, it starts off as inflammatory in the beginning, but it becomes degenerative. So we need to stir up the body's healing response by bringing more attention into that area by doing the soft tissue work, and that helps increase the blood flow, again, help heal. We may use taping as well. There's a couple of ways to tape for lateral epicondylitis. Some is to increase the circulation, like lymphatic flow. Some is to help raise the wrist. It's more mechanical. All our patients, we focus on proximal strengthening. There's strong literature that shows that there's a strong correlation with weakness in the scapula, the shoulder blades, and problems with tendonitis in the elbow. So pretty much weakness here creates you to have to work and use more force in your arm. Over time, that becomes a cumulative trauma, right? And everybody with these conditions are like pretty active usually, and they're like, when can I get return to sport? When can I return to this? And as therapists, we grade the activity for success. First of all, we wait until you're fairly symptom-free before we even introduce that kind of stuff. That's more sport-related. We do incremental parts of it. And then we might say that, for example, like if you want to golf, we might put a TheraBand on a golf club and start working some strength in there, building your tolerance. We would tell you then hit maybe a small bucket of balls and just do chip shots off the tee, very low pressure. If you're a bowler, maybe you take a weighted ball and have you just kind of move through like a slow swing. There's a million things we do to grade these activities to get someone back to doing their sport. The last thing we want is someone, hey, I'm going to go play something with my buddies. And then you got competitive nature, and then you're going to have, you're going to forget about your pain, and then you're going to be paying for it, and then we're going to set us back in the rehab. So that's our warning to those folks. So what are some other options that are out there for epicondylitis that are given? So cortisone injections are a little controversial in the way that they work great for some other conditions. Lateral epicondylitis, hit and miss. Some folks just go see the doctor and get injected, and we don't see them, and there's some pitfalls there, right? They get injected, they feel better, they didn't change anything in their lifestyle, and then they use their arm just as much as they were using it before, and then this thing comes back twofold. So that's some of the problems with cortisone, that it covers you up a little bit. and then you feel great and you wind up doing everything normal. So in conjunction with therapy, I think it has its place, especially with the patient that is kind of like plateaued or stalled in their rehab. Maybe it's warranted. PRP injection. I don't know how many folks have heard of this. This is platelet-rich plasma. Very cool stuff. Now, this is not covered by your insurance, but it's what they do is what I was going to say. It's like 90% effective. And what they do is they remove your own blood. You go to a physician's office, usually a sports med person, doctor. They remove your own blood. They centrifuge it, take out the platelets, inject it right at the same time, same day, inject it right into the tendon that's affected. That creates a healing response because the platelets are going to send signals to your body for healing. That's what the platelets do, right? They tell you there's an injury, we clot. We're going to send these markers for healing. And that lets your body know, oh, this is injured. We have to heal this. And that's how that works in short. 10X. Here's a picture of 10X here. Use ultrasound to guide the physician. This is a physician procedure. This wand that's part like needle, part vacuum. What they do is they kind of remove this degenerative tissue on the tendon and suck it out. And they're not going in blind because they got the ultrasound to see what they're doing. And then the tendon has a chance to heal and recover. Again, it causes a healing response too, because you're kind of scoring up that tendon a little bit. And finally is just open surgery. This is still a common way of fixing these, especially if they've been near a year out and they're just not doing well, or if you knew there's direct trauma to the elbow and there's really a potential for a partial tear of the tendon. In that case, they go in there, they open up your elbow, and they find the irritated tissue, the degenerative tissue, and they either scrape it. I've read different things, scrape it out or cut it out, and they suture it back together and they score up the bone. Again, that'll cause a whole healing response. And again, fairly good outcomes with these, 60, 90% effective with that. These take a little bit longer to recover though. You're not starting strengthening for like 6 weeks. You're not returning to work or like those kind of heavier tasks, let's say, more to closer to 3 months, right? So now we're moving on to arthritis. So just to talk about arthritis, arthritis is a thinning of the cartilage. Your body can't replace cartilage as it wears away or it gets destroyed by some mechanism. So your body can only produce bone in those areas. So I'm going to show you this picture here. You have an arthritic elbow joint, the olecranon here, and here's the humerus. And so you got these bone spurs, really thinning area. This would normally be a wider gap. So it's thinned down because you guys know, like if you ever seen x-rays, right? The bones look like they're not touching, but that's the cartilage touching each other. And you have these bone spurs just growing haphazardly, really. And they can cause pain because they can grow into soft tissue like your capsule, surrounding tissues, maybe muscle tendon, things like that, structures. So that can cause pain as well. But so osteoarthritis is that wear and tear arthritis that can happen over time in the elbow, which is possible, or post-traumatic could cause osteoarthritis as well, where maybe an injury like a fracture offset the bones, and now you have a pressure point where it's uneven wear and it starts to wear that certain area real thin, the cartilage. Again, it can't repair itself. Or if you have trauma through the elbow, you can fleck off a piece of cartilage, and then now it's like missing a piece there, and that could also become arthritic. But the more common type of arthritis is actually rheumatoid arthritis in the elbow. The elbow is fortunately not a very common arthritic joint for osteoarthritis, but more autoimmune disease is more of a culprit. So autoimmune disease, unfortunately, is the body attacking itself and attacking soft tissues, synovial fluid, line tissues, joint tissue. So you often see this not isolated in one elbow. Maybe it's, both elbows, hands, lower extremities as well. And so that is actually, we see more at the elbow with the autoimmune disease. So what can you do? Like you think, okay, arthritis for the elbow, right? What can you do for arthritis? It's permanent. Well, it's true, it is permanent, but we can make you feel better and maybe move better and be more functional for different reasons. So we could do modalities that kind of reduce your pain, work on range of motion. That's, between stretching and restoring some, sometimes you get like joint stiffness because of pain, you get contractures and joint stiffness. We can help free that up. Strengthening. Some of these arthritic joints become unstable because of arthritis. Strengthening can help stabilize those joints a little bit and make them feel more comfortable in activity. A big thing with any arthritis is joint protection principles and activity modification, right? Using your hand or arm a certain way where you're not loading forces unevenly through the joint. So you can do things that are just respecting what, the way the joint moves and not loading it in a way that causes pain. We might, suggest like an arm a sleeve like this, a compressive sleeve. Compression gives support, and it also gives you feedback through proprioception that actually reduces pain. So that's a simple thing that kind of helps with pain with any joint, really. And medications, right? Doctor may prescribe, or over the counter, someone might take NSAIDs, non-steroidal anti-inflammatory drugs, right? Or if you've got the autoimmune disease process going, then maybe a doctor would prescribe immunosuppressive drugs depending on the severity, right? Because there's risks of those drugs as well. They do shut down your immune system somewhat, but they may be warranted to prevent destructive process of autoimmune disease. And finally, we're going to talk about our third section here, elbow fractures, elbow sprains, and elbow bursitis. So when we talk about fractures with the elbow, it's any of these three bones. Now, this is not a normal elbow X-ray. I'm going to get into this condition here, but you got the distal humerus, right? That's part of the joint. You have the ulna here, which has been posteriorly dislocated, but just the ulna and the olecranons, this part of it. And then you got the radius, which is here, and mostly the radial head, which has been fractured. Some fractures require plating to help stabilize. Some fractures are non-displaced and they just need to be immobilized for a certain period of time. Usually with the elbow, they don't want to ever immobilize more than 3 weeks. 3 weeks is the magic number for the elbow, because after 3 weeks, it's really hard to get your range of motion back. So even with non-operative elbows, they do try to get them moving in some degree at 3 weeks. So let's get into this picture here. This is called a terrible triad. And believe me, if you've got a diagnosis of terrible triad, that's not a good situation with a name like that, right? So we have a radial head fracture. The radial head is like a spool-shaped bone that allows you to forearm rotation. So most likely they would this looks like this is comminuted pretty good, meaning it's multiple pieces, so that I think they would replace the head on that. This ulna has been this normally sits under here, completely shoved back, right? This is a high force trauma, usually the arm out, dislocated back. So with a dislocation and fractures, you have usually soft tissue injuries as well, like the ligaments involving with the elbow. And the coronoid fracture is part of this triad, right? Just three things: the radial head, the dislocation, and this coronoid fracture, which is the tip of the ulna here on the front side. It gets broken off because the ulna got shoved back really quickly. And again, with traumatic fractures, you're at risk of osteoarthritis based on forces through the joint if it disrupted the cartilage, or fractures disrupting the cartilage. And just to share one more thing about the elbow. We call the elbow the unforgiving joint. That's what we call it in therapy. And we call it that because it is it overreacts to injury in a way of swelling, stiffness, and pain. So whatever happens to the elbow, it just kind of gets magnified. And so the rehab process can be a little bit longer with severe injuries to the elbow because of this. And we're going to talk about that now. So a key thing in for elbow fractures rehab is restoring that range of motion, right? The elbow joint's so critical in your function of your arm. In just the elbow itself, the flexion extension, and the supination and pronation of your forearm, right? The ability to turn your palm up and face your face, or you turn your palm down and grab something. Same thing with the reach, extension for reach and flexion to reach your face for, hygiene, eating, hair care, right? All these things are so important. And they could be tough to manage. So, and talk about managing our patients, we look at, like, did they have the surgery, or did they need surgery or not surgery? We don't look at having plating and surgery as being like really a complete negative, because surgery and plating, and this is not just for the elbow, it restores the positions of the bone anatomically the best they can, right? So you have a chance of getting your joint in the most normal anatomical, we call it anatomical position, the way it normally is. So you can have the best chance of good motion and not having a problem with your cartilage, like I was talking about. And you can start movement earlier than waiting for a fracture to heal without surgery. So, and as we progress these patients, we want to work on functional strength, of course, as their fracture heals. And I want to talk about this device here. A lot of times the elbow, because it is a tough joint to rehab, we had to pull out some other devices. So we might suggest using a static progressive splint like this. This is something that the patient would use at home to help stretch their arm in extension and in flexion. This splint does both, and they just crank it and it holds them in that position, and they can control the resistance, which is really good. The force on their arms, so it's very tolerable. So elbow sprains. Now these elbow sprains, notable event usually, right? You fell on your arm, or it got twisted somehow, right? Sometimes arms get just caught up in something, and your arm gets torqued a certain way, and with a sprain, think about your ankle. You roll your ankle, you sprain your ankle. That's what's happened to your elbow, right? You pulled the ligaments. You've created some kind of tearing in the ligament at some degree, right? And if you did, it's going to be painful. There's going to be localized swelling, just going to be bruising at that area. If it's severe, you might have clunking or clicking, right? Because it's maybe unstable. We're going to talk about special tests for the ligaments that in the next slide, just to kind of show you what we do in the clinic to test these guys out. If you would be advised to see a doctor first with these to make sure you get x-rays that kind of rule out fractures of the bone, or just, there's another type of fracture with ligaments, is where a Volgin fracture, where the ligament didn't break, but it pulled a piece of bone off. So that's very possible as well. An MRI may be used too to get more information on the grade of ligament tears and soft tissue injury with these kind of injuries. So here's something you might see us do in the clinic, right, for elbow sprain. We kind of want to know, like, how stable is this elbow? How reactive is it to force? So the UCL is the inside of your elbow. That's the ulnar collateral ligament that stabilizes your elbow from going outward. Anyone that's familiar with baseball and the throwing athlete, the pitcher, the UCL is the ligament that is involved with the pitchers, and if they tear that, they get the Tommy John surgery. So the UCL is much more injured than the LCL, which is the lateral collateral ligaments on the outside of the elbow. So we do a valgus stress test. We just kind of unlock the elbow and load that ligament, and what we're doing is looking for how much pain with loading, right, and also how much laxity is in that ligament. Like, how far does it move out? And, like, we don't know what that person, some people are hypermobile. So they have a lot of laxity. Some people are really, you know, hypomobile and they really have a stiff joint. So we always test the other side. Always test the other side. That's how you know what normal is for them. And here's the other one for testing the lateral collateral ligament. This one you see that you put them down in on the plinth or on the table, and then you drive pressure into their arm, into their elbow, and you forcefully supinate, which is turn their palm towards their shoulder, and you put that valgus stress on there. And what you're feeling for, you got your hand over their radial head. And what you're feeling for is that the radial head's going to try to sneak out the back, because if that ligament's torn, it kind of wants to move. And often a patient won't let you get that far because they get apprehension. They feel that laxity there, and they tense up, and they don't want you to go any further. Just to visualize, like, here's the UCL again. Here's a normal one, right? It's intact. A partial tear, just imagine it's like a little nick in this thing, and it could be at varying degrees. It could be like 10%, it could be 80%, right? We don't know a lot of times. We might know by how much laxity and pain. That might give us an indication when we're doing that valgus stress test. And here's a full tear. If we load that with a full tear, that elbow would swing out quite a bit. Quite a bit. If they injured a partial tear or a full tear, you see here, there's this hinged elbow brace. This is a common protective device for the elbow, right? It allows the elbow to move in linear motion, but doesn't allow any lateral forces in the elbow, so those ligaments can heal, right? So you'll often see a patient with wearing one of them if they're dealing with that. So not to skip over, what if you have an acute injury, right? To your elbow, you fall, you hit your elbow, anything happens to your elbow and you need to, try to calm it down. You follow the ICE principle, right? ICE. And the good thing is the ICE starts with ICE, right? I for ICE. That's easy. And then compression, right? Maybe you have ACE bands laying around. You put some compression on it. Elevation, right? To keep the swelling down as well. And you want to rest it and maybe even immobilize it, and maybe take some anti-inflammatories, right? And then again, like I said in the beginning of this presentation, monitor your pain. Does it seem how you got to assess, like, how injured is my elbow? I think I fractured it. When I move it, do I feel something that doesn't feel right? Am I willing to wait on it the next day? Is it worse or better? Maybe worse. But as the days progress, is it getting better? If not, again, seek medical treatment, right? If you think, just to make sure you're not missing something. And our final slide is elbow bursitis. Not super common. But people fall sometimes on the backside or on the backside of their elbow and just hit that bone. And there's a bursa sac here. And now this illustrates this, like, makes it look huge. This is really thin. You can't even feel it. So it's really just to allow the skin to glide over the olecranon, which is that bone we keep talking about here on the posterior part of your elbow. So it just makes it friction free, right? There's a lot of movement of the skin. So it just helps it glide. So if you smack that really hard, it's a synovial filled sac. So it'll fill up with synovial fluid. And these things, I've seen these things get as big as like a half a tennis ball. And so the best thing for these is time, compression, and rest it, right? But if that's not working, the physicians, if you see a physician, they may offer to aspirate this. They may stick a needle in this and drain out the synovial fluid. No guarantees there, though. Synovial fluid may come back fully, may come back halfway, and may do the trick. So no one knows until you try. But if it's really annoying and getting in the way, a lot of folks get impatient with it after a couple of months. But these things do take weeks to months to resolve. Okay, so that's it. I thank you for your time.